Bridget Bradley is, let me just say, fantastic. She is an associate professor at Pacific University School of Pharmacy. She's worked with CareOregon many times in the past, a wonderful partner to collaborate with. As a faculty member at Pacific University, she maintains a clinical practice site at the Virginia Garcia Memorial Health Center in Hillsboro, Oregon. Yay, Virginia Garcia. So many amazing things that happen out there. As a clinical pharmacist, she practices under collaborative practice agreements for depression and anxiety and provides a training site for pharmacy students and residents. Bridget, you're also one of the most patient people I know, and thank you for putting up with the technological hiccups that we have here today. You just let me know anything that you need, and we'll go ahead and drive these slides for you.
All right, thank you so much, Paul. Thank you, everyone. Yes, as Paul mentioned, on this slide you see the Oasis and Mother to Baby, and so it's a website I will reference later as it's a great resource for those of us practicing in primary care, as they have fact sheets on all the medications written in patient-friendly language that can be shared. But one thing I did think I appreciated as I was putting this talk together, that they did have a statement that they do identify that not all people identify as men or women. And so throughout their website and throughout this talk, when using the term mother, I will be referring to the source of the egg and the uterus, and by father, the source of the sperm, regardless of the person's gender identity. So we can go to the next slide. And I think this was, Paul did a good job at the beginning of this talk, recognizing that perinatal period, those sudden stops can be risky. And so a pregnant patient may come in and they may be on medications that were just discussed, like methadone or buprenorphine, or they may be on mental health medications, something for depression and anxiety. And sometimes that abrupt discontinuation of those medications has its own risks and consequences. So it's really important to pause when talking to those patients, and I really appreciated the way Kerri framed it on that idea that, you know, it's not what you say, it's how you say it. So thinking about how to have that discussion about risk versus benefits with these medications for those patients. And so the next slide we're looking at is the changes that happen in pregnancy. So again, I'm a pharmacist, so we're talking about medications. And so there are some definite changes that happen throughout pregnancy. Females' plasma volume can go up 50%. Cardiac output can increase 30 to 50%, and the glomerular filtration, so how those kidneys are working, can increase by 50 to 80%. And what the end result with these changes can be on medications is they can change the volume of distribution. So where the medication's going, it can lower the concentration of renally eliminated drugs. So that is where sometimes you'll see medications need to be increased throughout pregnancy so that we keep the levels that are needed to maintain therapeutic effectiveness. Overall, for the general medication approach on this next slide, is in a perfect world, we would avoid medications in the first trimester. We do need to have an awareness that unplanned pregnancies do occur, and most often occur when the teratogenic potential of the medication may have passed. So I really think an important piece, and we'll talk about shortly, is that regular review of family planning intentions with the patient. If there is the opportunity to avoid the medications in the first trimester, even if a patient's not pregnant, we want to taper the medications if we're discontinuing. If we have a pregnant patient and the decision is to discontinue the medication, that would occur after there has been that risk versus benefit discussion. Ideally, we want to use monotherapy whenever possible, and that kind of gets to that point that was just discussed with the buprenorphine products. and where kind of those recommendations from the CDC and SAMHSA comes in is that, ideally a monotherapy product. But as new evidence is coming to light, that may not mean that it's not safe. It's just kind of that general practice is to use monotherapy and to use the lowest effective dose whenever possible. As a pharmacist, this next slide talks about patient counseling. So this is one way that I frame those discussions when I'm talking to a woman of childbearing age, or if I do have a patient that is pregnant. So reviewing the purpose of the medication. So why was this medication started? What is it indicated for? The proper use. So reviewing those counseling points on how to take the medication, and then transitioning into what are the potential risks to the mom. So this can include the medication side effects, but then we also can have that discussion of what are the potential risks if that medication is stopped. And then the potential risks to fetus and pregnancy outcomes. So what are the potential risks of the medication to the fetus or with the pregnancy? So is there a risk for preterm delivery, et cetera? And that's really where that risk-benefit discussion comes in. Framing it this way is helpful because it really allows the female to formulate their own opinions after hearing that risk-benefit discussion on how to move forward with their decision regarding the medication. So as I mentioned for this slide, we should always be planning. Preconception counseling should be routine for women of childbearing age. It's important to consider a medication with the lowest risk for women of childbearing age. So there's some examples with antidepressants. All the SSRIs tend to be generally safe throughout pregnancy, but we do tend to attempt to avoid paroxetine due to some cardiac issues that have been seen in the fetus. Similar, if we have a woman of childbearing age with bipolar, we tend to avoid Depakote due to the risk of neural tube defects, which we'll talk about. And then similar, if we're using the antipsychotics, clozapine can be a little bit riskier in our women of childbearing age due to the agranulocytosis and then the risk with breastfeeding with that medication. It's really important to continue this planning because we know that over the last 30 years, women's use of prescription medications during the first trimester have increased by more than 60%. In the US, 9 out of 10 women take a medication during pregnancy, and this can be over-the-counter or prescription, and 7 out of 10 report taking at least one prescription medicine. Again, the importance of planning, having that preconception counseling, and the general avoidance of medications that could be riskier in women of childbearing age is important because almost 40% of pregnancies are unplanned, with 22% are considered mistimed. So that planning piece is very important. So what do we know about medications and pregnancy? So we do know that every pregnancy starts with a 3 to 5% chance of having a birth defect, and that is referred to as the background risk. And as Kerri noted, that we don't have a lot of information about many of our medications during pregnancy. Fewer than 10% of medicines have enough data about fetal risk. One of the information sources that have been used are the pregnancy letter categories, which are those pregnancy category A, B, C, D, and X, which have now been phased out and have been replaced by the pregnancy lactation labeling rule. This new labeling rule includes information about pregnancy, lactation, and includes information for females and males of reproductive age. It provides information about the risks versus benefits for providers that they can use to counsel women so that they can make an informed decision. So this next slide shows those pregnancy letter categories. And so as many of us may have seen these before, category A was always very helpful there wasn't a ton of medications that included category A. These were medications that had studies that failed to show a risk to a fetus. Category X was also helpful because we knew to definitely avoid these medications as they have been shown to be teratogenic. Category B, C, and D had different levels of information from animal studies, which wasn't always helpful in knowing what the effect would be in humans. So really, they were often confusing. They did not accurately or consistently communicate the difference in the degrees of fetal risk. And so our next slide shows this replacing and this pregnancy lactation labeling rule. So again, it shows pregnancy risks, and so you can see all the different information that will be included if it's available. So one thing this does include is that pregnancy exposure registry. So I would encourage everybody, if you do have a woman that is on a medication during their pregnancy, to report that in the registry, because again, we don't have these studies done in women of childbearing age or throughout pregnancy. A lot of this information comes from post-marketing and these registries. So the medication will include a registry if available. It will then go through the risk summary. And so on the right, you can see that this is pulled from the package insert for Trintellix, which is one of the newer antidepressants. So that's one thing, is that medications that were previously approved have been grandfathered in. So not all medications may have this new labeling. So Trintellix was new enough that it does have this new labeling. And so you can see that it identifies that there's limited human data during pregnancy. It includes information on what they've seen, and goes over that again, highlighting that the estimated background risk is at 2 to 4, 3 to 5%. And then it will also include clinical considerations. So this part is helpful when it includes information about what are the risks of not treatment. So it will include that, and will also include any dose adjustments during pregnancy or the postpartum period if needed. And the next slide looks at kind of what's available with lactation. So this is really helpful because we're talking about the perinatal period. So after pregnancy, a woman may choose to breastfeed. If they are going to breastfeed, there may be a needed discussion of that risk versus benefit during that period. So this section will include what information we have about the presence of the drug in human milk, effects on a breastfed child, the risks and benefits, and then again, clinical considerations. So this information was actually pulled from Sublocade. So there was data from 2 studies of breastfeeding infants who mothers were maintained on buprenorphine 2.4 to 24 milligrams that showed exposed to less than 1% of the maternal daily dose. So very small excretion into the breast milk. And so this information would then allow have that risk versus benefit discussion that overall this medication would likely be safe for breastfeeding. Okay, I think the next one should be the females or males of reproductive potential. This is a new addition, and there's not always a lot of information for this piece in drugs, but this includes any impact that the medication might have on pregnancy testing, contraception, or fertility. So this, again, information is from Sublocade, and this is identifies that chronic use of opiates may reduce fertility in both males and females. And then includes that there's not a lot of information about fertility or impact on contraception. So overall, this new labeling rule includes a lot of information if it's available to have those risk versus benefit discussions. So now we'll briefly talk about medications and breast milk. So again, breast milk is a mix of living cells and fat cells. What determines if the medication may pass into the breast milk are medication properties and the drug transfer mechanism. Passive diffusion is the primary mechanism for transfer into the breast milk, but there's lots of medication properties that can impact if a medication is going to pass. So medications that have higher protein binding will have less ability to pass into the breast milk. Medications with a higher molecular weight would also have lower pass into the breast milk. If a medication has higher lipid solubility, that would also impact its ability to get into the breast milk. The clinical effect of the drug determined by how well the baby is able to absorb and metabolize the medication. We know that infants will have their metabolism, their liver enzymes, the way they process medications is very different than adults. And so that also needs to be considered with some of these medications. And so there are medications that are going to pass into the breast milk, but many times it's a smaller amount. And in the most cases, breastfeeding can be continued if that's the choice of feeding. So again, if we're looking for medications that are more compatible with breastfeeding, this list includes higher protein binding, the medication with a higher molecular weight, a medication with lower oral bioavailability, a medication with lower lipid solubility, and ideally a once daily medication, if possible, because then they're going to have less exposure, less peaks that could have the infant exposed during feeding. So again, let's talk about the risks versus benefits. So many women are going to need to take medications during pregnancy to control their health conditions. And in some cases, avoiding or stopping the medicine during pregnancy can be more harmful than it would be for that person to continue the medication. And so that discussion is started by thinking about the risks of no treatment to the mother and the risks of no treatment to the fetus. And then what if there's treatment? So what is the risk to the mother and the fetus if there is treatment? We can also look at the source of the data, the timing and the stage for risk, and if there is a dose associated. So what are the potential medication risks? So those can include birth defects or major congenital malformations, pregnancy loss, prematurity, infant death. There can be developmental disabilities, and then the CDC also acknowledges that potential unknown outcomes, so covering all their bases here. So considerations when thinking about a medication during pregnancy is how much medicine you take, when during the pregnancy you take the medicine, other health conditions you have, or other medicines you can take. So how much medicine you take. This is the next slide. So there are some medications that the dose is associated with more risk. So it has been seen that divalproex doses greater than 1,000 milligrams per day have a higher risk than doses less than 1,000 milligrams per day for those neural tube defects. Paroxetine, when the doses are greater than 20 milligrams per day, seems to be a higher risk. And for lithium, the cardiac malformation seems to triple when the doses are greater than 900 milligrams per day compared to 600 milligrams per day. And that's going to be associated with the amount of the medication that crosses the placenta and is exposed, and the fetus is exposed to. This next slide is thinking about when during the pregnancy you take the medicine. So this chart is summarized from mother to baby, and it looks to think about when does fetal development occur. So the brain and spinal cord, when we're thinking about a medication like Depakote, which can cause neural tube defects, it's that first 16 weeks when there's major structural defects can occur. And so that's something to consider with Depakote. So if a patient comes in and they have been on Depakote for 12 weeks, that discussion may center around, you know, what can be done now at this point, and knowing that a lot of those major structural defects may have already occurred with that exposure, especially if that dose was greater than 1,000 milligrams. Similar to a lot of the major structural defects for the heart occur within the first 6 weeks. So if a patient is on lithium or paroxetine, a lot of that risk may occur within that first trimester. And so then, so understanding what the risk of the medication is and where during fetal development they were taking the medication can help frame those discussions about risk versus benefits. And then we can also think about, is there a risk at delivery for postpartum hemorrhage or bleeding, or side effects from the infant for withdrawal syndromes, and is there a risk postpartum? So some of these medications, we may have increased the dose during the 3rd trimester, and postpartum, we may need to decrease that dose to avoid increased side effects for the mother when that cardiac output, all those things go back to baseline. We also want to think about other health conditions the patient might have, because this can have potential impact with medication discontinuation on their other conditions. So if we have a patient with depression on an antidepressant and they have comorbid insomnia, if we stop that antidepressant, now we may worsen their depression may rebound as well as their insomnia. Substance use with comorbid anxiety, again, if we are adjusting medications for one, we may need to be thinking about what other comorbid conditions could worsen during this discontinuation time if that risk versus benefit discussion leads us down that path. Also need to think about other medications you take. So again, there's potential drug-drug interactions if changes are made. So we want to keep that in mind. And so some really helpful resources. So I've mentioned mother2baby.org. This website's really helpful. It includes fact sheets for many of the medications. Again, they're written in patient-friendly language, and they go over what if I'm on this medication? Should I stop it? Is it going to impact my ability to become pregnant? It talks about pregnancy and lactation. So it's a really good resource. There's also a question, you can submit questions and get help on information about medications. This other one, the NCBI website, this is LactMed. So this is a website you can go to, and this is a great resource to evaluate the medication if it is compatible with breastfeeding. So you can search for a medication. It will give information about any data that is available about fetal or infant exposure to medications during breastfeeding and any levels associated with it. The other resource for those of us in Oregon, I would say, is also the OPAL, OHSU Psychiatric Access Line. That resource is also really helpful for psychiatric questions that you can call the psychiatrist up at OHSU and get advice on medications and having those discussions. So some great resource, again, Mother to Baby, LactMed, and OPAL. So let's talk about some of the medications. So substance use. Kerri just did a great job kind of explaining all those pieces that we need to think about with substance use. So with opioids, if a woman is using opioids, they're going to be at risk for preterm birth, stillbirth, and poor fetal growth. And if we withdraw the medication, we're associated with higher relapse rates. Talked about alcohol. Again, very good evidence that alcohol should not be used during pregnancy. Increased risk of miscarriage, premature birth, and low birth weight, as well as a risk of fetal alcohol syndrome. More than 30% of pregnant women enrolled in a substance use treatment program screened positive for moderate to severe depression, and more than 40% reported symptoms of postpartum depression. So again, thinking about those comorbid conditions that need to be considered when thinking about medication discontinuation during pregnancy. So for a woman that is pregnant and she's being treated for substance use, I think it is important that pregnancy alone is not an indication to change a woman who is stable on an opioid agonist to another opioid agonist. So as Kerri mentioned, this is going to be that risk versus benefit discussion. So if you have somebody who's been stable for a long time, you can have that discussion about stopping or tapering off the medication. If you have somebody newly started and stable, it may be more appropriate to continue that medication. There may be less risk with continuing that medication than stopping it. For substance use, for treatment risks, naltrexone, again, can be used. Kerri had mentioned buprenorphine has less severe neonatal abstinence syndrome. There seems to be low risk of birth defects with buprenorphine. Methadone is one that may require dosage adjustments during pregnancy. But again, as she mentioned, that dose is not associated with the fetal withdrawal length or severity. And then buprenorphine and naloxone does seem to be similar to buprenorphine monotherapy. So again, if a woman is stable on buprenorphine and naloxone and becomes pregnant, that's not an indication that they need to switch to buprenorphine or to methadone for any reason. If they're stable on the medication, it's usually best to continue it rather than switching. We just know that continuing these medications reduces the relapse risks. It improves their prenatal care, and so they really should be continued if the woman needs to continue on these medications. And we have low risk to the fetus to continue them. For depression and pregnancy, we know that 14% of individuals will develop depression during pregnancy. There's sometimes this idea, again, this is, it's not what you say, it's how you say it sometimes, that, you know, that a pregnancy could be protective, that the woman should be happy, it's just such a wonderful time, and that's not the case. It does not impact the depression positively for some patients. We know that untreated depression is associated with stress, decreased social support, poor weight gain. Women can then smoke or use alcohol or substance use, and poor prenatal care. For the fetus, that untreated depression has been associated with premature birth, low birth weight infants, and fetal growth restrictions. And if the antidepressant is discontinued before or during pregnancy, those women have a 5 times more likely to have a relapse than if they were to continue their depression treatment. So again, pregnancy does not protect against the occurrence of depression. And the SSRIs are the most commonly used and best tolerated treatment for depression, and they do carry just a small risk for serious medical consequences. So this next slide has our depression and anxiety medications. So again, the top table has the SSRIs, or the selective serotonin reuptake inhibitors, and below that are the SNRIs, so our serotonin norepinephrine reuptake inhibitors. Overall, the SSRIs are preferred in pregnancy. The one that is not preferred would be the paroxetine, due to the risk of some cardiac effects that we're seeing. that does seem to be dose related. For fluoxetine, some may tend to avoid this medication because it has a very long half-life, although there has not been any increased risk of birth defects seen with that medication. Sertraline does seem to be the one that is most commonly used in women of childbearing age or during pregnancy because it also has favorable data for lactation. And the SNRIs can also be used. There is a small potential increase with venlafaxine, but again, overall, the risk is low with all of these medications. The next slide has some of our newer antidepressants that work a little bit differently. So bupropion or Wellbutrin had a low absolute risk of left ventricular outflow obstructions when used in the first trimester. Mirtazapine does not seem to be associated with major birth defects. And then vilazodone or vortioxetine, again, are our newer antidepressants. And so there's really limited data to assess. So for women of childbearing age or within pregnancy, really would stick with our SSRIs or SNRIs over vilazodone or vortioxetine, just because we don't have that data. If they are on those agents during their pregnancy, please report that to the registry so that we can get additional information to help guide in our decision making. And then when we're talking about anxiety, we also have our benzodiazepines. Our diazepam has that longest half-life, so we tend to avoid. But overall, we tend to avoid our benzodiazepines for long-term treatment or as monotherapy for anxiety. We do have a treating anxiety ideally on an SSRI or SNRI, and then these would be using the lowest effective doses. So for depression, again, avoiding paroxetine, although the risk is still really low. I'm kind of summarizing the other agents. I didn't mention the tricyclic antidepressants. They do have data within pregnancy just because they're the oldest antidepressants that we've had. But due to tolerability and their side effect profile is going to be less tolerable than an SSRI. The TCAs are going to have more sedation, more constipation, which isn't ideal throughout pregnancy. One other point to mention is with the SSRIs at delivery, there can be withdrawal symptoms for the infant. So this can include irritability, jitteriness, trouble sleeping, or trouble eating. So again, just monitoring them upon delivery. And then those symptoms are usually short-lived and can be discharged home as expected. So thinking about a patient case, so if there was a 26-year-old female who was 22 weeks gestation at her first prenatal visit and the pregnancy was unplanned, she's been on paroxetine 20 milligrams daily for 1 year. She denies using other antidepressants previously. This is her first episode, and the OBGYN calls you to help with the major depressive disorder management. So how would you educate the patient? So again, I try to follow this kind of form of discussing what the purpose of the medication is, to improve the depression symptoms and avoid those outcomes that can be associated with not treating depression, proper use of using that 1 tablet daily, potential risks for the mom, so any side effects associated with paroxetine, and then potential risks for the fetus. So cardiac defects, again, with doses greater than 20, so if they're at 25 milligrams. Early delivery, spontaneous abortion, and lower birth weight. If we think back, that major structural malformations for the heart would be usually within the first 6-7 weeks and she's 22 weeks pregnant at this point. And so that would be one discussion, that there could be some additional screening through ultrasounds to see if there's anything noted. And then that would be the discussion if we needed to continue the medication. One way to discuss continuing the medication for this patient is that she did just have her first episode. She's been on the medication for a year. We could evaluate her symptoms more effectively with like a PHQ-9, see if she's in remission, and then discuss tapering off the medication if she just no longer needs the medication. If she's still having depressive symptoms, would continue the medication. But if it's her first episode, she may be able to stop this medication. She would want to be watched closely due to that risk of return of depressive symptoms during her pregnancy or postpartum. And so that would definitely be a discussion. But for other patients, if this was a patient that had, 3 or 4 episodes of depression, the risk versus benefit may favor continuing the medication versus stopping it. For this patient, the ideal situation probably would have been not having her on a medication like paroxetine, just because it's riskier and she was of childbearing age. So having her on sertraline or citalopram or a different SSRI. Also having a regular discussion with her if she were planning to become pregnant, and if she was not planning to become pregnant in the next year, what was she doing to prevent pregnancy, since this was an unplanned pregnancy. Okay, and for anxiety, very similar treatment with depression. So just because we're treating anxiety, it doesn't mean that the risks of the medication changes. Some medications that come into play for anxiety can be buspirone, which has a low risk associated during pregnancy, and then the benzodiazepines, which may be associated with increased risk of miscarriage, but also the risk is, there is a potential risk, but it's low. But again, we want to ideally not have these as monotherapy and not long-term. We know that women that have anxiety during pregnancy have increased risk of complications, including preeclampsia, preterm labor, infants with low birth weight. So we do want to manage this anxiety. If the patient were on benzodiazepines, there are going to be some associated withdrawal side effects, and the infant would need to be monitored at delivery for these withdrawal symptoms. For bipolar, similar to depression, there's this idea that it could be protective, and it is not. We know that patients have a high risk of relapse without therapy. Patients can have both depressive or manic and hypomanic episodes. The postpartum period can increase risk, and a lot of that is associated with the lack of sleep that can occur postpartum, which is frequently a trigger for episodes within bipolar. So really important to have early discussions about planned pregnancy. And this can be very patient-specific, pending their severity of their bipolar. Again, monotherapy is going to be preferred if we can. So one of our gold standard treatments for bipolar would be lithium. And it does have some risks for Epstein's anomaly, specifically because this is a heart malformation within that, if it's used during that first trimester. That is recommended that if a female is on lithium, to complete a 20-week fetal anomaly scan. We do have to monitor lithium pretty closely baseline, but during pregnancy, we would monitor it a little more closely during the 3rd trimester due to some changes that occur. May need to have increased levels or increased doses. And for breastfeeding, lithium is generally discouraged due to it has a very low or narrow therapeutic index. And so the infant would be exposed to medications, and we just don't really have a lot of information about the levels that the infant would be exposed to. And we would also monitor for hypothyroidism with lithium, because we know that lithium is associated with hypothyroidism. There's also some delivery complications for infants, so they would be monitored. Usually if a patient is on lithium during pregnancy, they're going to deliver, it's ideally if they deliver at a hospital that has a NICU in case there are any complications. Another medication we use for bipolar is valproic acid or Depakote. Ideally, this medication should be avoided in women of childbearing age because it is associated with neural tube defects. If a woman of childbearing age is on this medication and they could become pregnant, it would be best if they were taking folic acid 4 milligrams a day. And if they are pregnant, then definitely taking folic acid 4 milligrams per day. In 2011, the FDA did report that Depakote's associated with birth defects and decreased IQ in the child, but Depakote is compatible with breastfeeding. So different than lithium, when we would usually discourage breastfeeding, Depakote can be used. Other common medications for bipolar is lamotrigine. So this one also compatible with breastfeeding. We know that it is cleared faster during pregnancy, so they may need, you may need to increase the dose if their symptoms are not controlled, and so would monitor postpartum if they need to decrease that dose. And that there have been some case reports of cleft palate, but that's been not confirmed in other studies, so we're not still unknown what the risk with lamotrigine would be. This lamotrigine does have the risk of Stevens-Johnson syndrome, so it can be compatible with breastfeeding, but would need to monitor the infant for any signs of rash. Second generation antipsychotics are also used for bipolar. Seems to be low risk for birth defects with second generation antipsychotics. Most are compatible with breastfeeding with the exception of clozapine. Again, due to the risk of that passing into the breast milk and the risk of agranulocytosis with clozapine use. So if we have a patient, we have another 29-year-old female, and she presents to discuss preconception planning. She recently started a prenatal vitamin, and she would like to become pregnant in the next year. She's currently on lithium 1,200 milligrams. And she was last hospitalized 7 years ago and has not had any mood episodes in the last 3 years. She's not currently on any other prescription or OTC medications. And so when we're thinking about educating this patient, again, we're going to think about what is the purpose of the medication, what's the proper use, the potential risks, and then the potential risk to the fetus. So again, this is an ideal scenario where we're having that preconception planning, having those discussions. And so in this case, this would be the opportunity to try decreasing the dose, seeing if the symptoms are managed. We know that doses above 900 milligrams have a higher risk of those cardiac defects. So this could be an opportunity to try to decrease that medication to see if we can control the symptoms at a lower dose, even at 600 milligrams, and then monitoring or evaluating, you know, does she want to become pregnant in the next year? Would we have time to decrease the medication or have a trial off the medication before she were to become pregnant? So when we're deprescribing medications, we really want to evaluate the risks of continuing the medications, having those patient counseling points, and then those risks versus benefits with the patient so that they can make the best decision for them. So if we are deprescribing, we've made that decision to deprescribe. So at this point, the risk versus benefit favors deprescribing the medication. ideally tapering off the medication, because abruptly stopping these medications, depending on what the medication is, can be more risky for the mom to have a relapse if it's a substance use medication, or withdrawal symptoms with a lot of the antidepressants. We want close follow-up to monitor for withdrawal and return of symptoms. And so I know the previous cases seemed pretty straightforward, and so this one is more realistic to what I might see in clinic. So we have a 25-year-old female wishing to become pregnant. She has a significant past medical history for both depression and anxiety with PTSD. She has migraines, she has ADHD, and she has allergies. And then she has a complete medication list here of being on bupropion for depression, Adderall for her ADHD, Depakote for migraine prophylaxis, along with escitalopram for her depression, quetiapine for anxiety. Then she is taking a prenatal vitamin with just 1 milligram of folate in it, diclofenac, fexofenadine, and montelukast for her allergies. She's got rizatriptan for her migraines, pregabalin, fluticasone, and she had Mirena, but it was recently removed because, again, she is wishing to become pregnant. So what medications, concerns, and mood stabilities concerns do we have? So for this patient, one of the first things I would recommend would be, if she is wanting to become pregnant, to evaluate getting her on a higher dose of folate because of that Depakote use. Also would ideally look at that Depakote and see if we can change that medication or taper off that medication because she does appear to be on it for migraines, and we may have a better option for her that would be less risky if she were to become pregnant. She's currently on 2 antidepressants, both bupropion and escitalopram. So would also have that discussion if we have an opportunity to consolidate to just 1 medication, although both of them have low risk during pregnancy, but would want to evaluate if we could just be on one treatment, and then would evaluate the use of quetiapine if that needs to be continued throughout her pregnancy. And then the pregabalin, that one I'm not sure the indication, so would need to double check, but this one would definitely be that risk versus benefit, and probably right now the riskiest medication is that Depakote. So getting her on 4 milligrams of folate and seeing if we could stop that Depakote would probably be the priority for me for that patient. So help avoid sudden stops. So really need to have effective communication between providers as to who is prescribing the substance use or behavioral health meds and what should be continued. Having that risk versus benefits review, again, how you say it is important. And then abrupt discontinuation of medications has its own risks and consequences. So sometimes continuing the medication is the best thing. And with that, thank you very much.